Do you want me to turn the recording on, KB?
I think I just pressed it, but
Okay.
yep. Cool. And you can still see the same screen, right? Awesome. All right, so today I'm just going to be presenting an overview of CBT-E. And if technology works for me, and Audrey will attest that it didn't work so well for ISED, I have a little quiz set up. So if you can also have like your phones nearby at the end, just so that you've got another device. So I guess I'll try and take us through. Some of this will, I guess, all be common sense, but please like interrupt, add comments, ask questions like the whole way through. I might just have to speed us along if we get stuck on a bit, just so that we get through it all, and then hopefully we'll have a bit of fun at the end. So just an introduction to CBT-E. So you're probably all very aware that it's derived from CBT by Aaron Beck. And Aaron Beck sort of describes in his introductions to CBT that it's not the situation in of itself that determines what people feel or how they respond, but rather the ways in which they construe a situation. So then obviously CBT-E was first then developed by Chris Fairburn, and it was developed specifically, and it was actually called CBT-BN, my apologies, for bulimia nervosa in the 1970s. Then in the early 2000s, it was expanded out to the enhanced version, along with his colleagues Cooper and Safran. And I guess that's the manual as we know it sort of today, and it's now sort of applied to all eating disorders. So I guess the core principles, so Glenn Waller kind of talks about it as being like keyhole therapy, which I think is a great analogy. So we're looking at just like the minimal invasion for the maximum effect. So we don't want to like drill down unless it's absolutely necessary to like the root or the origin of the eating disorder, because we know that we just need to focus on the things in the here and now that are like maintaining the eating disorder. So Waller again also describes CBT or CBT-E as just really focusing on that core psychopathology, knowing exactly what it is that you're trying to repair. So in particular, like faulty like cognitions and assumptions around eating and weight, and then also having the right tool at the right time to address the problem. As you'll be aware, CBT-E is very behaviour focused. So it's not just a talking therapy, that the change lies in changing the behaviour itself. And therefore, there's a really strong emphasis on tasks that happen in session, and then a really strong emphasis as well on what happens between sessions. There's a really strong focus on behaviour change from the start. So Glenn Waller in particular is a really strong proponent of us not spending too much time focusing on motivation and engagement, but rather that seeing change early is engaging and motivating in of itself. This is a little quote from the CBT-E manual. So Fairburn says, "The most powerful way of achieving cognitive change is by helping patients change the way that they behave and then analysing the effects and implications of those changes." And the therapy itself, as like structured and predictable and kind of persistent as it is designed that way and is intended to be engaging in of itself. So it kind of matches some of the like characteristics and the needs of clients in those early stages of their treatment. And I had one client in particular sort of tell me, I think it was lightheartedly, that I was as rigid and persistent as her anorexia. And when we had a bit of a laugh and talked about that towards the end of treatment, she actually helped me understand that CBT-E in its framework and its delivery almost kind of mimics anorexia. It's predictable, it's consistent, it's structured, and that in the early stages of treatment, as much as someone might resist it, that there's something that's also like containing in that of itself. And obviously, while CBT-E is very collaborative, it also is quite dependent on having that like firm empathy approach. So we have like clear expectations and boundaries. We hold clients accountable to achieving the change that they've said they want to come along for, whilst also being understanding and empathetic of the ambivalence and the fluctuating motivation they might experience along the way. So I guess what we've talked about, it really focuses on what's keeping it going. The transdiagnostic view is one, I guess, that sort of sums up all eating disorders, and it sort of says that all eating disorders in the here and now share an overvaluation on the control of eating weight and shape, which leads to a form of restriction restraint. Then that either kind of goes down the green pathway and ends up in a low weight, which maintains the dieting and the focus on weight, or it leads to binge eating, and either binge eating on its own or binge eating and compensatory behaviours. But at their essence, they all share this overevaluation of the control of eating and weight, and attempts at strict dieting in an effort to lose or maintain their weight. So there's three main goals that CBT-E spells out in the textbook. So the first goal is just to reduce the eating disorder psychopathology. The second goal is to correct the maintaining mechanisms, which we'll talk about a little bit further on, but sort of being the overvaluation of weight and shape, restriction and restraint. And to ensure those changes are maintained, which is a real strong focus of the end of stage 3 and 4, where we're starting to like prepare for wrapping up and equipping the client to be able to maintain the changes on their own. So CBT is intended to be a complete therapy in of itself, which I think that we now do really well at CFIH, but in the past it was not uncommon that someone was doing CBT-E in conjunction with another therapist, or the same therapist also doing another therapy, so schema therapy or trauma therapy, and those things running concurrently. Whereas what the manual says, and we do now, is get people to solely focus on CBT-E of itself, see what kind of falls away, and then reevaluate the need for additional therapy for other problems at the end. So as we know, it's time limited, so it's not expected or necessary that the patient achieves full recovery in the duration of treatment, but rather they're given like the skills that they need in order to keep being their own experts and continuing along their like pathway towards recovery even after treatment has been wrapped up. And there's quite a bit of research that like the lack of a time frame can just delay change. So if we're not sort of kind of bound by our 20 sessions or 40 sessions, and I'm sure anyone that's worked in mental health settings outside of CFIH or outside of our service delivery model can kind of attest to how many sessions you might just spend with someone talking about changing as opposed to them changing. And I've definitely, something I've been working on more recently is at the beginning of every session telling clients what session number we're up to. And even sort of more recently with a client who's doing really well in treatment, saying to her, we're at session 12 of 20, you know, you're making great progress, but we really need to get a crack on. So I'm going to leave you to keep working on the regular eating on your own, and we're going to start moving on to the next module that's really important for you to start to get some skills around. And I did sort of see her really take a lot more ownership around regular eating and kind of step up her game a little bit more with that extra nudge and that extra urgency. And as we know, it's an individual therapy, but that the manual talks about how we involve significant others. And as we know, the clinical guidelines for the treatment of eating disorders also recommend that we should also be seeking to involve significant others throughout the course of treatment. So who is it for? So it's recommended by the NICE guidelines as the one of the leading treatments for adults with an eating disorder. It is suitable for complex clients, and I really love this quote from the textbook again, where Fairbairn says, complexity is the norm rather than the exception with patients who have an eating disorder. So we don't want to ever write someone off as being too complex for CBT-E. As we often talk about in the clinic, we're actually really poor predictors of who will respond well to what treatment at what time. We want to give them a go at the best delivered version of CBT-E possible and see how they go and reevaluate along the way. Obviously, CBT is also for patients who an eating disorder is the primary focus of treatment. And I think something we've been speaking about in the clinic more recently as well is somebody who has an active eating disorder and has like active behaviours that are maintaining an eating disorder as well. So as we know in recovery, somebody can restore medically, physically, they can have a duration of time where they're not engaging in eating disorder behaviours, but the cognitions and the body image concerns are sadly the last thing to change. But I suppose as ACT, acceptance and commitment therapy, would sort of say is that rather than trying to like change those thoughts, we just sort of want to like notice them and not act on them, which is where we're trying to get our clients to towards the end of treatment. And therefore anyone coming along who's not engaging in disordered eating, even though they still have their thoughts, is probably not suitable for CBT-E. The textbook says it's for patients who are moderately underweight. The textbook doesn't specify moderate as less than 20%. It does still talk about BMI, and I'll speak a little bit at the end of this presentation around how we at CFIH uphold model fidelity and also adopt a social justice weight neutral approach and hold those two kind of competing demands at once. The textbook says as well for like milder presentations, which I think is something for us to think about as well if we're not able to keep up our KPIs around wait times, is that for milder presentations, particularly binge eating disorder or milder versions of bulimia, that we might want to consider self-help versions instead of a course of CBT-E. Although CBT is appropriate for like complex and severe clients, it does rely on a degree of insight and motivation change. So obviously we need to be holding that in mind and always considering whether CBT-E in an outpatient setting is the right treatment for this client at this time. And in more severe presentations, the textbook recommends considering a preliminary intervention first. So with our adults, that might be that they go into a day program or have an inpatient admission first, or for young people or adolescents, the textbook says to consider FBT first, which, as everyone would know at CFIH, is our first line approach for anyone aged under 18 living at home. Is there any questions or comments so far? You're all still there? Still awake? Okay, so possible contraindications. Obviously, anyone who's medically compromised, and that's why we have the systems and processes in place to make sure someone's safe to be in outpatient treatment. Someone who's like acutely suicidal, obviously that's different to someone having suicidal thoughts but no sort of intent or plan, and that's something we're also needing to keep an eye on throughout CBT-E. If someone does admit to having ideation but no plan or intent, that we're just following that up along in treatment. The textbook says depression can be a contraindicator, and I think, like we've talked about before, just something for us to think about here again is whether we would necessarily turn someone away, given that like restrictive, low weight eating disorders are commonly associated with mood disturbance, which is obviously different from clinical depression. But also when we keep in mind that the first line treatment for clinical depression is medication and CBT, it might again be a case where we trial someone at CBT-E, and if it's not working, get NYA's input and see if medication and CBT-E can help them along the way, or whether they need to go and do a course of CBT for their depression first. With regards to persistent substance misuse, the textbook actually says that this can often be kind of incorporated into the formulation, and if addressed well with like expectations and non-negotiables, it can be managed and treated alongside the eating disorder. But obviously it's like we need to monitor closely, and if obviously someone's coming along to treatment actively under the use or under the influence of substances, that's a whole other issue. Major life events or crises. So if a patient feels like it's something they just need one session to talk about in the midst of treatment, and then they can continue with treatment, that doesn't necessarily preclude them from treatment. But if, say, somebody's suddenly homeless or in an acutely dangerous situation, like CBT is unlikely to be their priority, and we're probably better off pausing treatment, having them going attend to those other life issues so they have the stability that they need to kind of commit to treatment first and foremost, which speaks to that point. Bree looks after all of us and makes sure that our clients' treatments aren't interrupted by our annual leave. And the other considerations are just around weight and BMI. So I guess there is some literature that says that anyone with a BMI below 16 is less likely to have the cognitive capacity to change, to engage in treatment and to change. I think that in our clinic, again, we would consider whether there was a possibility of a more intensive treatment, like an inpatient admission if it was required. Otherwise, we might just give them a go at CBT-E anyway and see how they go. And I suppose the other one to think about is just our clients who present shortly after having had weight loss surgery. So for us, we just ask that the person's weight is stable, that they're not continually actively losing weight in treatment. And that goes for someone with or without having had weight loss surgery, but particularly in the case of weight loss surgery, that their weight has been stable for a period of time and they're able to commit to maintaining or restoring weight, and that they feel like they're able to do that in the context of the weight loss surgery. But if those things aren't able to occur, we might ask the person to come back to treatment when they feel like they are able to stabilize their weight. This is just a little tool that's been developed by the NEDC that kind of looks at what prevention, early intervention, active treatment, and then recovery and relapse prevention entails. Obviously, where we're most positioned and where CBT-E fits is in this first phase of treatment, which is the community-based treatment, in which it's recommended that evidence-based treatments are delivered in the community in an outpatient setting. And then I guess this is just another little tool. We don't have to think about this too much because all of our pre-treatment phases are kind of set up to make sure that we're only seeing the patients that kind of belong in outpatient treatment. But if it is of any interest, this was just a tool that was developed by Josie Geller in trying to consider whether someone should be in outpatient, day program, inpatient, or a residential program. And it's, I guess, basically just based off severity of eating disorder, symptoms, and medical stability. So there's been some adaptations to CBT-E. So it has been adapted by the Dalligrave group in Italy for inpatient settings. And that's a little image of his version of the step up, step down program in which they use CBT-E, but it's more and less intensive depending on what level of treatment the patient's engaged in. And then obviously in the CBT-E textbook as well, there's a specific protocol and chapter dedicated to patients who are significantly below the weight that they need to be at. My transitions haven't worked. So the manual actually says that to consider FBT for anyone aged under 15, that CBT should only be considered for adolescents over 15 years. However, again, there have been adaptations again by the Italy group for adolescents aged over 13 years old. And if we are, I suppose, treating somebody, which we kind of don't at CFIH, that's aged between like 15 and 18 with CBT-E, there's adaptations in the CBT manual for adolescent kind of versions of CBT-E. And I guess the biggest difference is that parents are more actively involved, and there's protocols around what time allocation should go to the patient, what should go to their parents, and kind of clear expectations around what topics should and shouldn't be covered. And then the final adaptation, I didn't really speak about groups, but the final adaptation would be CBT-T, which was Glenn Waller's group in the UK that has been developed for patients who aren't below the weight that they need to be, and it's a 10-session intensive version of CBT that's gotten really good outcomes. Are there any questions about like the adaptations to CBT-E? No, I'm going to test you and quiz you all soon. So I don't know if this is interesting to anyone else. It took me so long to get my head around this. So with CBT, there's two forms, the focused form and the broad form, and two intensities, the 20-session version and the 40-session version. I don't know if you all already figured this out, but you can have 20-session focused form and 40-session focused form, and also 20-session broad form and 40-session broad form. So just to kind of knock them out a little bit, the focused form, and to me as well, the words don't make sense, and I mix up focused and broad all of the time because in my mind, those words don't well describe what they're intended to. But the focused form is like the default version. It's indicated for most patients, and it focuses exclusively on the eating disorder pathology. There was some mixed messages about which one was more or less effective. Overall, focused and broad haven't been shown to be found any more or less effective than one another, but the focused form they found was often better delivered and more effective with the majority of patients. So the broad form is just for those patients who have like a pronounced form of clinical perfectionism, core low self-esteem, or severe interpersonal problems that are, I guess, severe in of themselves and also appear to be uniquely contributing to the maintenance of the eating disorder above and beyond, I suppose, that transdiagnostic general core psychopathology. So the manual says that all patients should start with the focused form, irrespective of whether or not those additional factors, perfectionism, core low self-esteem, or interpersonal problems are evident from the outset, and that the decision to move from focused to broad should only be made as part of the stage 2 review, when it's become really evident that one of those additional factors are severely getting in the way of treatment. So then in terms of the intensity, the 20-session version is when significant weight restoration is not needed, and it's 20 sessions over 20 weeks. At CFIH, this decision is generally made during the assessment by the assessment clinician. And if the treating clinician is seeking to move someone from a 20-session version to a 40-session version, then it gets brought to case review. So the 40-session version, and I guess I want to clarify, because I think there was some mixed messages in the clinic as well. It's not sort of based off anyone's complexity or based off whether they might have those other pronounced issues. The 40-session version is when significant weight restoration is required. So that's 40 sessions over 4 weeks. And again, it's determined in the assessment by the assessment clinician. Does any of that come as any surprise to anyone else, or you all kind of got that much earlier and easier than I did?
Yeah, no, I just remember doing supervision with Catherine and kind of, there was a few light bulb moments for me as well. And one of them was that you can do the broad form with the 20 session version. But if you are, say, doing perfectionism within the 20 session, it does have some implications about how you lay out session. Like you're actually covering, there's one body image, then restriction, restraint, or moods, events, then the broad form. So it might be that you extend the session, or it might be that you have another session that particular week, because it's really hard to fit everything within 50 minutes. Yeah,
so it's pretty intense and intensive.
Yeah.
I think also after our training with Anthea, I didn't realise there seems to be not much of a difference, even when there were, say, very clear issues of perfectionism that was a contributing factor. I think she said there's not clear evidence that doing the broad form gives you a higher recovery rate. Then I'm thinking, oh gosh, let's just do the I'm not. Occasionally I do add it in, and out of all the modules, probably the perfectionism one is the one that, if I'm doing a broad form, that's probably the more common one. I don't know what others think. The interpersonal stuff, I find that's very much overlap with the moods and events stuff, so that you're doing moods and events, and you can't, it's different. But anyway, I'm not attempting, because they feel like harder skills to be really good at, so I tend not to do it. I don't know what others.
And that's great, because like one of the key principles of CBT-E as well is it's better to do a few things really well than try and attempt to do many things and do them poorly. And I guess what I could find was that there's not a great deal of like training. Even the manual is pretty vague in terms of rolling out the focus, the broad forms, just to mix them up. And overall, they were found to be as effective as one another, but that the broad forms often not as well delivered, and there's not as much clear guidance around how to deliver it anyway.
I think what I used to find too, when I would try to incorporate it, that you're already in those later stages of treatment checking in with so much stuff as it is.
Yeah.
And then you can feel almost a little bit sidetracked, and like you're not focusing on the problem anymore, and you're trying to cram so much into the weeks that you've got that, I very rarely, I don't even know if I've done it in a year. Like, honestly, I can't think of the last time I did perfectionism or self-esteem specifically. Like you said, no, in moods, that stuff comes up often. So
I'm doing with a client at the moment, and Danica and I have popped in our request to go and do the IPT training. So don't crucify me that I've not had it yet. I have read the manual, but I'm doing broad form 40 session with a young person with severe and enduring anorexia who is actually getting through the components of eating disorder stuff quite well, but has struggled to individuate from her mother and develop a sense of self, and kind of put in boundaries around wanting to weight restore and eat more, even though her mother has her own unresolved eating disorder. So that was one where she my support is more around being an eating disorder specialist, but she needs more help around like developing the sense of self and managing her relationship with her mum. So she's one that we are doing that with. But other than that, I would also agree, more often than not, I probably count on one hand the number of times I've used the broad form.
Yeah.
In terms of the intensities as well, I guess one thing I wanted to share was I did an assessment at the Sunshine Coast for someone who is low weight anorexia. However, she came off the Marina, however I pronounce it, sorry, hasn't got her period back for a period of time, works in health herself, and became quite anxious about what that meant for her own bone mineral density and fertility. So sought out a friend and a GP who had interest in eating disorders, and the friend had a history. And by the time she came along to her first assessment, she'd already gained 7 kilos on her own. And I did say in the assessment, this is normally the decision we're making around 20 session version or 40. You are low weight and you have a lot of weight to gain, but I kind of feel like putting you in the 40-session version, we would be unnecessarily protracting your treatment. And if anything, I think like a bit of a push in some of the intensity that will come from trying to get through it in 20 sessions might actually be more helpful. So that was just a one-off case where we decided to start with the 20 session and review in stage 2, just because she's made so much progress on her own. I don't want to unnecessarily or unduly have her attribute her recovery to us. So this is just a quick little summary. So the forms and the different forms and adaptations in just a summary table. So we've got the focused version in the 40-session version, the broad version in the 20-session version, which obviously then has the additional modules below it. There's the CBT-E underweight version, which is the 40-session version, and you may do that focused or broad. And then there's some of the adaptations that we kind of talked about for younger patients, inpatient, and I didn't talk about group adaptations. So then we have 4 stages. So we know that stage 1 is really just about achieving early change. It's really focused on helping the patient understand the problem and really start to establish a pattern of eating that is regular and addressing any of the relevant issues that might come up around that. So if they're purging or if feeling full are issues and barriers to stage 1, we would be addressing those things. But if those things aren't relevant, obviously we would just be like focusing on getting them to eat regularly, trying to get some early weight gain and really implementing some of those key components of CBT-E into the treatment early. Stage 2 is obviously where we do the review, which may occur over 1 or 2 sessions. At the moment, I'm like hugely interested in like reviewing the pre-EDEQ and then doing the EDEQ again in stage 2 together and like pulling up both of the results and looking at them. It's been really rewarding for me, but I've also found just how much change people can make in just stage 1 when we're not even addressing body image concerns, and how no longer restricting, binging or purging in of itself reduces the focus on weight and shape. So obviously in stage 2, I guess that's where we're going to really like take the plunge. And we're going to design stage 3 of treatment. So it's at this stage that we'd be deciding whether we're going with broad or focused. And then that's where we start to look at body image, dietary rules and restraint, moods and events, and those additional modules if they've been identified as necessary. Then in stage 4, we're starting to phase out treatment. So the frequency becomes less frequent, less regular, but we're also phasing out monitoring, weighing, those sorts of things, and starting to kind of prepare the patient to be their own expert. I just sped through all of that. I'm sure you all know that inside and out. So the outcomes for CBT-E, when delivered well, 2/3 of people who complete treatment achieve a good state of recovery. However, there's so much like literature about like the difficulties with model adherence, and I'm so proud of our team and what we do. So there's a significant proportion of clinicians don't weigh their patients, don't do the formulation, don't get their patients to do monitoring and don't review the monitoring in session. And those clinical tasks are obviously like so core and fundamental to CBT-E that I think that if we could as a field all get better at adhering to the model, that we would probably see better rates of recovery from CBT-E, but also eating disorders more generally. The group at CCI did a really great study a couple of years ago where they showed that actually patients with severe and enduring anorexia respond as well as patients with early onset first presentation. And I think, again, that kind of mirrors our experience here. I think we do a really good job of just giving someone a chance at really good, well-delivered therapy and not colluding with the duration of their illness, the severity or complexity of the illness, and or the fact that maybe they've had eating disorder treatment beforehand. There's been some studies that have shown that the recovery rates that have been demonstrated by like the ivory towers, like the Oxford group and Credo group, have been replicated in real world settings. There's minimal difference, like I said, between broad and focused form. And Glenn Waller's group in particular has put out research showing that clinicians who have regular supervision, who monitor their outcomes and bring their outcomes to supervision, actually get better outcomes, which I suppose is not at all surprising. So just what CBT-E says around like therapist characteristics. So women, the manual says, like, may have some advantage, just in that their patients may be more likely to be female as well. But as we know, we're getting an increasingly number of non-binary or male patients. And the textbook said that obviously, like, training and competencies for like far surpassed someone's gender or age. And own eating disorder history is not relevant either. It might make someone more, I guess, like attuned to other things to look out for and to be able to empathise with the difficulties a patient might be experiencing. But obviously that's not going to be shared with the patient directly, so it's not sort of really relevant in terms of therapist characteristics. It's not necessary, but prior training in CBT-E is definitely helpful. I think particularly given CBT-E as a manual lacks like a lot of nuance, like it doesn't really give a rationale or explain like what is a behavioural experiment, what is the theory behind it. So that prior training can be really helpful. But you do need to have obviously an understanding of eating disorders, some counselling skills, an ability to be firm and fair, have consistent boundaries and expectations, and be non-judgmental. The other bit for therapist factors, the textbook obviously recommends to have training in CBT-E, and ongoing training and revision of CBT-E. So kudos to all of you for being here in masterclass and revising CBT-E today. Obviously, you need to have access to the manual and the supporting texts. It really recommends checklists to support like our model adherence. And I'm kind of halfway through 2 projects. One is updating our clinician handbooks for CBT-E, but also reviewing just the NUCL templates so that we hopefully have, you know, printable checklists on our desk that we can easily access. But also when we're going through and preparing or writing up our notes, it's also front of mind in terms of what was meant to be in that session. Regular supervision, reviewing outcomes. And then these are kind of like the little integrity checklists that I developed for the workshop that I ran, and I'm hoping to print them all off and put them in a folder, leave in the lunchroom to get everyone's feedback. But they've just been adapted from this article around, have I put the right one there? Well, that's ED15. I've not pasted in the right article, sorry. There's an article again by the Italy group where they have developed competency checklists for each of the phases of CBT-E. So it's just been adapted from that. So then resources. This is actually a picture of Renee's textbook. I took a photo because I just loved how well used and color-coded it was. Obviously, the textbook does say to refer to the Overcoming Binge Eating book and to provide it to your patient. I think that before you go and give it to someone, it is helpful if you've read it and skimmed through it so you can kind of anticipate whether or not it'll be appropriate or how you might have to preface that book before giving it to a patient, and keeping in mind some of the issues that might come up while they're reading it. Obviously, we have our treatment folders and we have our clinician CBT-E books to also accompany our practice. So I guess before I go into how we deviate a little bit, just in terms of how we understand like weight, did anyone have any questions or comments? Was that?
Just on the outcomes, yeah, I think I'll just take away using EDQ more routinely at stage 2 and possibly at the end of, you know, towards the end of treatment. it would be nice if our initial EDQ can be broken down into the subscales.
Yeah. Then we might need to put that up as another student project, just for someone to like figure out how to score it and set that up in
We tried pretty hard with Emma to do the subscales, but it's just the program that we use for scoring wouldn't allow it.
Oh, okay.
Yeah, we have to change the system that we use to a new scoring system.
On a positive, I've started our dashboard project as well, which would be starting to move towards like weight charts being automatic and electronically mapped out along with like symptoms, and like a graph of the EDEQ over time. So maybe as part of that, I'm going to eventually get tripped up and have to find a way of scoring up the subscale somewhere. But yeah, it would be good to have that. I'll definitely add it down as our like future projects now. Were there any other comments about the overview or questions? Chelsea, I know you've not been to CBT-E training yet. Did you have any comments or questions?
Comments is that was really helpful and insightful. Questions, I'm not sure if I've got anything coming up just yet. But yeah, that was really helpful. I appreciated it.
Oh, good. Thank you.
It's okay.
Can you still see my slides? Yeah. So I guess the main part where we deviate from CBT-E, and I guess this is also, I've pinched some stuff from my slides, our slides with Audrey, was that at CFIH, obviously, we don't think that eating disorder severity should be determined by someone's absolute weight. So sort of their BMI or the weight that they present at, but rather someone's level of weight suppression. So the textbook does still say, it still regards underweight as a BMI below 18.5. Unfortunately, so do many of the other CBT or CBT textbooks for eating disorders. But in our clinic, I guess we think more about severity around what percentage of weight somebody has lost. So if someone has a BMI of 25, but they were pre-morbidly a BMI of 35, in our clinic, we classify them as being underweight. So I guess I just wanted to be really just upfront and honest, because, you know, model fidelity is something that's like really important to us at the clinic. And this is something that we do deviate on, I guess, in how we understand weight and estimating expected body weight. This little table, Audrey, where did this come from? It was from a guideline.
Adolescent, what was it called? The something adolescent guidelines in America, anyway. Yeah. So
they were sort of supporting a move towards someone's deviation from their pre-morbid weight as being more indicative of mild, moderate, or severe severity, as opposed to just absolute weight in of itself.
And there might be a difference if we use BMI versus percentage of estimated body weight too.
What was that, sorry?
So this one uses BMI, but if we use, similar, but that could be different if we're just using, you know, how we normally calculated expected body weight. And yeah, so they're two slightly different measures as well.
I think that cutout that Kiera's got there they would use it was the Society for Adolescent Health or something. They would use either below BMI 16 or loss of 10% body weight. Is that what you mean, yeah?
No, but that figure says if prior to their illness, if their BMI was 20, and then now their BMI is 16, then they've got more than 20% loss of BMI.
So
usually would correlate. A drop in your BMI is usually caused by a drop in your weight, but I'm just saying for some people, They're two slightly different measures.
Slightly different measures, yeah.
Percentage of expected body weight or percentage of BMI lost are two slightly different measures.
Yeah, and I guess when I read like body mass lost, I was thinking body mass in terms of weight, not specifically body mass index lost. But I guess like and you do make an important distinction. I think the main point is that we don't use just standardized BMI in of itself, that we're looking at like deviation from premorbid weight, which is not what CBT-E does talk about. So it's one place where we kind of really differ quite a lot.
And I would say like most of the literature would look at premorbid suppression being from premorbid weight, not just, you know, like you can use BMI or you can use suppression from premorbid. Like this is one paper that's sort of deviated into mild, moderate, severe. There's lots of literature that says like weight suppression, and they measure it in all kinds of different ways. And some of them would just talk about like a 5% loss of premorbid weight.
I think as well, if our field was all more consistent in terms of how they understood underweight, how they calculated expected body weight and the expectations for weight recovery, and we combined that with model fidelity, I think we would have much better outcomes in the field, because even the clinicians that I know that deliver CBT-E really well, as we all know, if you're trying to help someone maintain a BMI of 20, doesn't matter how good you are at delivering CBT-E, if they need to be a BMI of 28, but they're kind of conceptualizing this person as being healthy, like no amount of CBT is going to be helpful for this person. They need the expectation and the support and the clarity around weight gain. So I think that's really something exciting that hopefully we can contribute in time. All right, let's see if technology does me any favors. So if you want to get out your phones and scan this barcode. Has everyone got it? Cool. Now I just have to go in and press play, I think. And do you all have the same screen as me? And I can't see you because I've just put it on full mode.
Yeah, so I can see the same question. Do we just click through at our own pace?
That's a really good question.
It looks like you do.
Once you send one, it doesn't tell you the next one.
Well, maybe can we do one at a time, just because I put in little leaderboards.
Okay.
So question 1, true or false? CBT-E is not for complex and comorbid presentations. And I'll just do a little manual countdown from 5. So, oh no, I stuffed it up. What's happening?
Do you just hit next? You keep hitting stop. Maybe you're just supposed to hit next only.
Oh, you're quite right. Thank you, Audrey. I really can't figure out this quiz thing. Yay! So you all got it correct. And Danica is so far at the top of the leaderboard. Question 2, which of the following is not a form of CBT-E? 20-session broad form, 20-session focused, 40-session broad form, 40-session focused, or as many sessions as the patient needs. 3, 2, 1. Ah, you've nailed it. So all 4 of you got it right again. And Danica again. Speedy. So number 3, true or false, the broad form is more effective than the focused form due to the inclusion of additional modules. 3, 2, 1. And you're all correct. And Danica's speeding along again. I think she might be skipping ahead.
I think she's got good internet connection. It's the NBN.
Well, you're all being my guinea pigs, and I'll see if I can put timers into the slides next time. So next question, how many sessions long is stage one, sorry, in the 20 session version, excluding the assessment? So 4, 5, 6, 7 sessions. I think the last one's meant to be 5 sessions. I can see as your answers are going up now. Ooh. So 3 of you are correct. So it's 7
I changed
sessions.
my answer to the wrong one. I had the right one before.
That's okay.
Oh, I shouldn't have changed it.
Do you know what? It'll stick now and you'll always
Yeah.
remember. Oh, Nyan's catching up. She's overtaken. So which of the following is not a module within the CBT-E focused form? Body image concerns, core low self-esteem, clinical perfectionism, or interpersonal problems?
Not a module. You can't answer 3 things.
I don't know if you meant broad form, KB.
Yeah, I wonder if you meant broad form.
I would.
Yeah.
I'm going
Still
to think
hasn't-
that she meant
Yeah.
Or you should have allowed us to tick multiple things.
Sorry, team. I really, as much as I can't get those words to stick to which is which, I know what the 2 forms are, but use the terms intermittently. All right, so it's in the broad form, the modules are core low self-esteem, clinical perfectionism, and interpersonal problems. So body image concerns is not a standalone module.
Nothing one.
I think this is just going off time. I don't know. Seems like a good idea at the time to add in something a bit more interactive. How many sessions long is stage 1 in the 50 session version? In the 40 session version? Sorry, this late last night, excluding the assessment. 7 sessions, 10 sessions, 12 sessions, or until 90% of expected body weight is achieved. So how many sessions do we have in stage 1 of the 40 session version? Either my connection's slow or this one seems to have slowed everyone down a bit. So the answer is 7 sessions. So stage 1, from my understanding of the textbook, and it's in the summary of the slides I showed, is that stage 1 is still the same, and the stage 2 review still occurs at sessions 8 and 9. And then stage 2 is longer when it still has a focus on needing to gain weight and bedding down those eating behavior principles, but you're also then starting to incorporate at that stage some of the other modules. Did anyone else have a different understanding? Because this was one of my other takeaways as well from reviewing the textbook inside and out, but it was kind of news to me. So if I've misunderstood it, I'm very kind of happy to hear from other people.
Yeah, I just always thought of stage 1 as, oh, sorry, go on.
Oh, no, you go, AR.
I just always thought of stage 1 as longer because you're doing the motivation to change and taking the plunge, and that's all part of, like, it's a protracted version of getting to stage 2. Yeah, but
that's how I felt similarly, in that every 4 sessions you do like a review, and it might be because of the motivation stuff, which should be 3 or 4 sessions, that you might need to extend stage 1 past session 8, but there gets to a point where you can't just keep extending it. You have to move into stage 3. So there's not really a definite 10, 12, 7 or anything like that. It's just I think there would be probably a limit of like 12, I think. Yeah.
The little summary I took from the text said so stage 1 is always sessions 0 to 7 and it's twice weekly, and then stage 2 is sessions 8 or 8 and 9 in both. But then because then if we're in the 20 session version, stage 3 is then sessions 10 to 17. But if we're in the 40 session version, it talked about that stage 3 is sessions 10 to 37. But that in that stage as well, there's still like ongoing like mini reviews, ongoing focus on some of the components that are also in stage 1 around like changing eating behavior, but that you might start to look to introduce some of the modules from stage 3 as like a bit of an extra like carrot by that kind of stage 3 like session 10. And then stage 4 in both versions, the textbook said was 3 sessions, 18, 19, 20, 38, 39, 40, yeah, 3 sessions long in both versions.
Our SDM, we're having, if they're doing the 40 session version, they're having twice weekly session till session 10, aren't they?
Yeah, at the moment, yeah.
But I mean, I can go back and look again, like the textbook doesn't have like this table in of itself. It doesn't actually have any little summary tables. And I do swear I read it inside and out. And it was news to me because I always thought that stage 1 is longer in the 40 session version. But in my most recent review, that's what I sort of took away. But I even wonder, could we set it as like a bit of a like homework task for all of us to go back and maybe think about where did we
stage 2 review for our CBT masterclass? Someone's surely doing that.
Good point, Audrey. Surely, let's have a little look.
And we just put it down as something that we want a bit more clarity on as a team about at what point we're doing it and what point we're saying we're moving forward into body image, even if there's no weight gain, and you know.
I remember in Anthea's training, she says most people start stage 2 too late, like they wait too long to start stage 3. Yeah, and you need to do stage review really early, not much earlier than you think.
Sorry to be a time Nazi, but my client's here.
Yeah, I've got 3 more questions. Can I finish those, or do you want to just jump off, Audrey, and I'll finish?
Is it okay? Because I've got 3 in a row, and I'm trying to be really good with my clients. That if I start on time, I end 10-2, and I'm like more organised.
Okay, all right. I can just wrap it up there for all of us, and I'll just learn to manage the time a little bit better.
Keep quizzing if you want.
It's okay. I'll let us all go at the same time. Thank you for everyone participating, and I guess if we could all bring our thoughts around where stage 2 comes to the stage 2 masterclass.
Review the chapter.
Yeah.
Thank you very much, KB. That was excellent.
Thank you.
Thanks.